Hello, we're going to go through how to get your Becker drain for your EVD ready for when the neurosurgeon is ready for them to connect it to the EVD drain. So for us to do this, we will grab the Becker drain itself. I generally get a couple of sterile flushes to prime the tubing and sterile gloves for myself as well. So usually I want some counter space. I don't have the greatest counter space. I might throw my cardboard over here for now. To give myself some space, but usually we'll set up and kind of prepare my set here. So I will generally have these off to the side. This I will open. See if I have enough space here. Oh, I should have my gloves elsewhere. And then the other thing, there we go, is I will usually go ahead and drop my sterile flushes on top here to have ready. Which is easier said than done, as it really goes out the outside. So once I have dropped those onto my sterile field, I'll go ahead and put on my sterile gloves, sterilely. Don't judge me if this is not super sterile with my example here. Try to get on my watch as much as possible. Okay. So there is a plastic covering over this itself. Obviously, I should probably be wearing my mask while I'm doing this. I'm not doing that right now just because we're doing a video. So you can pull this off. And if you have the trash can nearby, I just drop it. Sorry, not on your fit. So then for my sterile flushes here, I'm just pushing some of the air out of them. I have this stopcock and then there's a dead ender on the end right here. So this part that's down is going to eventually connect to the patient. As you can see, this part right here. And then the other part that is right here is going to be going to our drain that is the EVD. So usually what I will do is drop my cap over there. I will save this dead ender because you will want to eventually put it back on. So keep it somewhere handy on your sterile field. Connect your saline flush. I generally will push a little bit of fluid first into the part that goes up to the drain. Not a whole lot, but just enough so that when we actually connect it to the patient, it may take them a little bit to get fluid in. It's easier to see their ICP when you're trying to do the ICP and see whether or not they're fluctuating when you initially place it. So once I have that in there, I will turn it off to that, and then I will push it through this all the way through. So I will start pushing. Sorry, I'm getting my hand in the way for that. And then all the way to the end there. And it has an open end so it can actually come out the end once you've done that. So this one particular kit comes with like this little puncture safe on the end right here. I also want to try to get the fluid out of that as well. So what I do is I actually will turn this and take it off, trying not to drop this into unsterile territory, and then push the air out of that as well. So that's coming out the top, as you can see. And then we will put our cap back on. And then we have that set primed. So once I have it primed, the hard part is getting this dead ender back on without letting any air in and all that stuff. So actually the easiest I've found is if I turn the stopcock back off to where the flush is. I try to leave it as wet as possible, drop that, keep the cap that I left on my sterile field and put it back on there. So you now have this primed to hand off to your neurosurgeon that places the EVD. Neurosurgeon will tell you where they want the EVD drain set itself. It'll be in centimeters of water. So usually they will generally say 5 below, 5 above, 10 above are some of the most common ones. And this one will unscrew, and then you can bring it down. The arrows will line up where they want it. So if we want to go 10 above, we line up the arrows and then we just screw it so it tightens here. In terms of where the drain is itself, below the drain, there are 2 clamps. We will slide these closed. These clamps will be able to be unclamped each hour when you are starting to calculate your outputs from the EVD. And then below these 2 clamps, if I can get it clamped, is the actual drainage bag for long term. This just has hooks that it hangs on. It comes out like this. You can hook it back on and it kind of slides in. So that's kind of the basics. Make sure that you have it there. When you first start and the physician inserts the EVD, you may not be able to right off the bat when you connect it, have it leveled off to the patient's tragus, which is in line with the ventricles. But usually if you're at the bedside, honestly, I kind of do an eyeball from away to make sure we're kind of close. And then usually when they've connected it, they'll still sometimes have you clamped until they get a CT to confirm it. So then once it's confirmed, you can do with a level to the level of the tragus on the ear at the 0 mark to their tragus and make sure that it's level. Then you can open it up to the patient, which means you turn it this way so that the patient is open to drain. So now we're going to move on to showing you how to set up the transducer to connect to the EVD, the external ventricular drain, to connect it to your monitor. Obviously, you might have a different monitor than us, but most monitoring systems you can set up to do the ICP monitoring. So what you will need is a saline that is preservative-free. You will need some transducer, so usually a pressure tubing set. Just so you're aware, certain sets you'll be able to prime the saline and then disconnect the tubing itself. For our specific tubing, it's actually fused, so I'll show you if it's fused, what you have to do in that case. We'll open this up here, and I will say when we are actually getting ready to connect this tubing to the EVD itself, we want to be as sterile as possible, so you probably want to have a pair of sterile gloves on hand to change into when you actually get ready to connect this to the EVD itself. I am not sterile right now, but I do already have gloves. I don't want to waste more since we're doing education video. So I will, let me poke. Try to burp my bag as much as possible. Get as little as possible. Not that it matters much, but. Okay. So just like you would with any other pressure tubing, we're gonna go ahead and hold on and prime it to get the air out. Make sure there's no air bubbles in there. I'm doing the full tubing, but the reality is I'm gonna be losing the end of this tubing in just a moment. So then I'll bring this on over here, and I'm gonna hang it off the pole that my Becker drain is sitting on. So for our particular tubing, let me get rid of the Velcro on here. We will not need this. Wow. You see that we have this extra part on it. So I will usually change this out. Most of your pressure tubings will come with dead enders, so we will put a dead ender on our white part here. Once again, sterilely. Right now in my video, I'm not super sterile, but all of this you want to be as sterile as possible because this is basically a wick to the brain. And put that dead ender on. So then the other thing, I need to disconnect this section. So that just comes off. And then you see that I have it primed all the way up to it. So this is where I would probably take a break and switch into sterile gloves if I did not already have the sterile gloves on, which I probably should have for the dead enders and this part here. But I'm going to be connecting it now over to this dead end right here on the EVD itself. So I'm going to turn the stopcock off to that section, although that's going to start flowing this. Hold on, let me stopcock since it's not actually connected to a patient, so it doesn't drain it all out. So I'm going to take off this dead end. Maybe my finger muscles are not strong enough. I'm going to get my hemostat because I have no finger strength.
I can edit this part out.
Yeah.
No problem.
Loosen it up there.
It's called movie magic.
Movie magic. Okay. So I'm going to take my dead end off here. And then there might be just a touch of air. Sometimes what I'll do is I will try to, before I actually screw it on, flush that air out. And then we're going to twist this part on. So for some of you, you will have tubing that will allow you to twist this part off and put your dead ender right here. For the tubing that we have, it's actually fused, so we are unable to do this without cracking the whole thing. So to compensate for that, we don't have it on a pressure tubing or a pressure bag, as you can see. We'll just bring this roller clamp down, and we basically just put a sign that says, leave this clamped, do not flush this, do not touch this. It does not go on a pressure bag for most people. So we now have it connected to the patient. Then we will be taking a pressure tubing, and you will connect in to where you connect to your pressure tubing, and you will then connect to the monitor. Should I hit my display on here, close the window. So when I plug it in, it will pop up with whatever name. I can click in and I can change it to ICP. And then it will have it for my ICP. Now it will want me to zero it out. So for zeroing, you can see that I have two different stopcocks here. You can do it where the stopcock that's with the patient's EVD is off to this, and then you're gonna turn this off to patient, and then open your drain. Then obviously, sterile as possible. You can go up, click in and say 0 ICP, and then you will have your 0. You can return your dead end cap, sterilely, turn this up, and then if you turn this off to drain, then you will have patient right here, open to transducer, and you will get a transduce waveform, which we'll show you on a patient in a second. If you are trying to do the transduce, it's not a continual, it is a spot check because it has to be close off to the drain in order to do it. If you get a number and it is up like this or down like that, it is not an accurate unless you have that waveform and you are off to the actual collection drain. So we are getting ready to get supplies to set up for placing a EVD, external ventricular drain, at the bedside with the neurosurgeon. So just for our facility, I just wanted them to know where our supplies are located in ICU. So in our closet next to the tube station, we have some supplies up on this upper shelf here. We will need to grab a cranial access kit for this. We will grab for ourselves a Becker drain to set up, which we have video on how to set that up. We will grab the drain itself. Let me show you. The ventricle catheter that the neurosurgeon will use to place inside the ventricle. And then usually we will grab sterile gloves, gown, bouffant cap as needed. And then we will grab some separate supplies for us to do our own setup for the Becker drain itself. In addition, we also have levels up here, which you will probably want to grab one of the levels because we'll be leveling the drain to the patient as well. Okay, so now we're going to go through how we do the maintenance on the external ventricular drain. So we will go through what we're looking at hourly, how we go measure our intracranial pressures with both the manual side and with the transduce side. And then we will then get into how we can do specimen collection from this device. So first and foremost, each hour, you're gonna wanna go in and confirm that you have, with a level, that you are leveling out and that it is on the 0 mark. On there is level with the patient's tragus, which kind of lines up with their ventricle, right there. So pretend like I'm me, we look for the bubble, we know that we're level, we're set. So we've confirmed level. If you are ever doing any position changes, you will want to clamp off to the patient, which is down, to do turns, head of bed changes, if you're traveling anywhere, just because if this gets below the patient, you could drain all their CSF. That is not a good scenario. So once we have leveled it, we will open it back up if that is ordered. Also, as you see, they put a note here. Usually you want to warn anyone that might come into the room to not adjust the bed because it is leveled and it's dependent, that drain is dependent on being level with that patient. So next thing is when we come in each hour, once we've established that it is level to the patient's tragus, we are going to look at the chamber. So this collection chamber, each hour we will come in, and we clamped earlier as we did in the preparation video to see how much fluid we have and what color it is. So is it clear? Is it pink? Is it bloody? And our level looks like it's approximately 12 mLs right now. So each hour I would look at that, I would unclamp and drain it down into the collection chamber here. And then I would reclamp after I've drained. I'm not gonna drain it right now because I'm gonna show you how to collect some of this specimen, but we will, in the meanwhile, check intracranial pressure. So if I look at the stopcock once again, I have the patient is a downwards one, and I want the patient open to the collection chamber to do my manual ICP. So I will take this and I'll loosen, bring it up to the top, and then I'm gonna lay this flat against the numbers here. So I have the fluid, which is harder to see since his is clear, that it will be fluctuating, which means it goes up and down a little bit, and then it will kind of settle into a number. We're gonna look at the left side, which right now it looks like he's approximately ICP level around in between 5 and 6, so we'll go with 5. And we're doing it in millimeters of mercury. So once we've seen what that is, we'll loosen this and bring it back to where the neurosurgeon wanted it set, which is 10 above for this particular patient. So my arrows are set to 10 centimeters of water above. And that was my manual ICP. To do the transduced, I go back to my stopcock and I see that I want the patient open to the transducer. So I'm gonna turn them off to the collection chamber. So once again, this is a spot check for this. And then we had shown you how to zero in the other video, so I'm not gonna show that. Actually, yeah, I'm not gonna show that in this one. But I have them now open to the transducer, and then you can see up on the screen, I have an ICP of 5, 4 to 5. We have it set up since they have arterial line that will automatically calculate their cerebral perfusion pressure, which is your mean arterial pressure minus your ICP. And then we always want to check that white waveform is showing that we have a good waveform for this patient. So that's something that's really important. That's why we only do stop checks, because see what happens when I turn it straight up, for example. I have not a very good waveform, so it can't guarantee the accuracy, but when I turn it off again to the correct direction, give it a second, you can see that I have that accurate waveform that says it's probably gonna be a pretty accurate intracranial pressure. So once I have done that, I wanna make sure before I leave the room that I have my stopcock back where I want it. Is it going to be clamped per the physician? Is it gonna be open? Usually if it's gonna be open, I just turn it off to the transducer so that it's open to patient and the patient's open to the drain, and then we are set at whatever level the physician or the neurosurgeon wants it. Okay, so another thing that you might have to do if this patient has the EVD in for a while, or if they just have a lot of drainage, is you may have to change out the bottom bag on the drain itself. So just so you're aware, it has little clips that come up and it kind of drops down like this, which also you can do sometimes if you're having a hard time getting this to drain out when you have these clips open. But it has a lure lock system right here. We do have extra bags separate from the Becker sets that are on that top shelf in the secretary's closet where I showed you where the other cranial access supplies are. So with sterile gloves, sterilely as possible, you don't want to be rubbing this around in anything. You're going to unscrew this and disconnect and then screw in the other one. And then once the other one is secured, you can put it back on the clips right there. So for safety purposes with these patients, usually once they have the drain in, where the closest stopcock is to them, I generally put one of our stat locks for our Foleys in and have this on the side closest to the patient so that if the drain gets pulled, it's not going to pull at the site of insertion where the EVD is at, but rather right here on this tubing. Oh, the other thing to note is that for our facility, in terms of our policies, anything from this stopcock that is closest to the patient's drain, this is neurosurgeon territory. We cannot irrigate towards the patient, aspirate from the brain, anything of that sort. The only thing that we can access if we need to, say it's bloody and it looks clotted off, we can sterilely access this port and irrigate away from the patient towards the drain to try to clear the clot. Otherwise, anything from this port towards patient is neurosurgeon territory.
And then you take that.
You will change out this and change to a different cap once it has been accessed.
You have to use the preservative-free.
You have to use preservative-free saline to irrigate. Use the sterile flushes just because we know those are preservative-free saline. Okay, so now we're going to go through how you can obtain a CSF sample from the external ventricular drain. Typically, you will need a couple of sterile tubes to send them to the lab. You will need a syringe and needle, and then a chlorhexidine swab and sterile gloves, because we want to be as sterile as possible. It won't be absolutely perfect with your sterile gloves, but just to kind of give you an idea. And then I'll go to steriles and get with my needle here. So, with the chlorhexidine swab,
or you could use alcohol or betadine.
or those two other options, I'm going to go over here and we are going to access the port that we have here in between our two clamps, and we're going to clean this hub. And make sure it is as clean as possible. The other thing, so that I can access this fluid, I'm actually going to unclamp this top part and see if I can get the fluid down into my chamber where the port is here, so that I can actually aspirate these. This is where I may have to bring this up a little bit higher. For now, I'm just going to clamp this off to the patient because I'm going to raise it and jiggle it. This is going to be the hardest part, and it's probably going to be getting the fluid to go down into this chamber here, which means I'm going to have to get a little squeeze at a time to kind of get the air to go out of this and down into where my hub is. So now you see I have a little bit of the fluid here, so I can actually get it from my port. Okay, so we will give it time for that to actually dry. In the meanwhile, I have my syringe and needle over here already. I'm going to clean and put sterile gloves on, because once again, sterility is key. This is a wig to the brain. You will also want to be wearing a mask if you don't already have restrictions in place for wearing masks at your facility. So once again, obviously it's sounding super sterile because I'm picking up this non-sterile syringe but I am trying my best not to touch that puncture site on the drain itself. So, we line up and we puncture in. So then we are going to pull back and collect our specimen here. So depending on what they want sent off will depend on how much you are collecting. So I've got about 10 cc's in mine, so I will pull this out. Now, sterilely once again, I actually have a helper into that. They will open it for me, and I'm gonna squirt 2 cc's in each of these. So give me a second here. It's hard because I'm trying not to touch any of the sides of my needle. Okay. And then we will repeat that for any of the other tubes that we need to send down. It is an irretrievable specimen, so we will have to walk it down with the patient labels.